This afternoon, I'm honored to present a case report titled Conquering the Obstacles During Interventions of Chronic Total Occlusions at the Proximal of Right Coronary Artery with a concurrent significant oscillation.
Into considerations during PCI, and there are several strategies to optimize support in concurrent CPO and oscillation of RCA. Thank you.
Okay, congrats. You highlighted the balance of the importance for a backup catheter, and also meanwhile you juxtaposed it with how you try to avoid pressure damping. But remember, this is a CTO case with left to right collaterals. You don't really need to be worried about pressure damping. Why? Because the issue with pressure damping is because we figure that the catheter might cause the diminished flow distally, antegradely. But in this case, that's not really important because you've got already a left to right collaterals. But the decision that you finally used the guiding catheter, I think, is a very smart one. But in other case, if you want to avoid pressure damping, you could have tried to put another wire down to the aortic root. Yeah, one wire going distally and one wire at the aortic root, so there will be no pressure damping. But in this case, I'm not sure that's really relevant. I would like to appreciate the way you tried to share your strategy to us in the first place about the escalation, the use of our escalated wire, and also the use of several devices, which was very gradual, and it's important for us because you showed us that in the first place you had very own strategy in tackling the lesion. I think that's all from me. Thank you.
Okay, thank you, Dr. Gaston. The last presentation is very interesting, and we can learn from this CTO step by step scoring. Takes the angiography rightly, and then plan how to do the approach the CTO, and stabilize, and delivery time, and then scoring about the GCTO, about the successful for CTO, and you putting step right, and picture pre and after the intervention you can see clearly. It's very helpful and documented. Thank you for your presentation.
Thank you very much.
Almost all presentation, 1/5 of presentation.
Inside the villa to come forward. Your time is 8 minutes for presentation and then 2 minutes for discussion.
Assalamualaikum. Good afternoon, Chair, analysts, and judges, and all the audience. First of all, I would like to thank to all my teachers, and this afternoon I'm honored to present a case report titled "Conquering the Obstacles During Interventions of Chronic Total Occlusions at the Proximal of Right Coronary Artery with a Concurrent Significant Oscillation." A chronic total occlusions, or CTO, is a complex lesion, and its treatment through PCI can be quite challenging. And it can be even more challenging when there is a concurrence of another subset of complex lesion, such as oscillation, because this may lead to some significant difficulties like poor angiographic results, difficult adjustments of guide catheter, the risk of pressure dampening, and the lack of backup support during PCI. Here are some statistical piece information regarding CTO and oscillation in right coronary artery of the RCA. The CTOs are most common in the RCA, and the success rate of the PCI of CTO in RCA is lower than in the LED. Oscillation accounts for around 7% of all coronary stenosis, and more than 2/3 of the oscillation involve the RCA. The oscillation of RCA will represent a greater challenge for PCI compared to the left oscillation. We would like to report a case of a 57-year-old male patient with chronic coronary syndrome, Canadian coronary score 2 to 3, who complained of worsening symptoms within the last 5 months. The patient showed no signs of congestive heart failure. From the past history, there is a type 2 diabetes mellitus, cigarette smoking. There was a previous PPCI procedure 2 years ago involving stenting in an LAD. The overall physical examination is normal, except for mild systolic murmur suggesting a mitral regurgitation. The ECG was normal sinus without any remarkable sign. The echocardiography detected a reduced ejection fraction of 44%, with regional wall motion abnormalities from hyperkinetic inferior and infraseptal segment. And also there was a mild secondary mitral regurgitation. Here, the left coronary angiography. The left coronary angiography revealed a normal LFGA. There is a patent old stent at the proximal of the ALD and a significant 80% stenosis at this time. The circumflex artery was also normal, providing grade 3 collaterals to the RPLB. Here, the right coronary angiography was not so smooth. There was failure to engage using Judkin right 3.5 catheter, so we have to replace it with Amplas left 0.75, and it was successful. Fortunately, there is no pressure dampening during engagement. It revealed a significant stenosis at ostial of the RCA and a CTO with bridging collaterals from the proximal to mid part of the RCA. While the distal portion was not well appreciated due to contrast interfilling. The likelihood of successful crossing is intermediate according to GCTO score sheet, so we decided to perform PCI with antegrade wire escalation strategy. Here we have a guide wire run through NS hypercode which failed to cross the CTO even with support from a 2 French microcrank port. So we replaced it with guide wire Miracle 3.0, which eventually succeeded to cross the CTO. And then we proceeded with balloon dilatation to modify the entry point. Guide wire 1 and as hypercode was passed distally as a body wire to facilitate focus of force angiography. Again, we perform angioplasty with larger balloon for optimal lesion expansion and this lesion preparation followed by stent deployment. At proximal to mid RCA using DES Amphilumus and ostial, and the second step at ostial to proximal RCA using BUMA. Here, after the two stent placement, angiographic evaluation revealed a significant 80% stenosis at distal RCA, so we decided to perform the third stent placement. To facilitate smooth delivery of the stent and the balloon, over the already deployed stent, we used Godzilla 2 guide extension catheter. The third stent was deployed safely, and the whole procedure was completed with sequential dilatation using a non-compliant balloon mosaic to a pressure of 20 atm over the deployed stent to prevent incomplete stent apposition or malposition. Okay, here is the final result. Was successful stenting of ostial proximal to mid and distal of RCA with TB flow 3. The pharmacological therapy included dual antiplatelet, high-intensity statin and ACE inhibitors and beta blockers, and the patient was stabilized and safely discharged afterwards with adequate counseling and education. Okay, for discussion, we highlighted two important points from this case. The first is engagement. We must be very cautious with pressure dampening, as it is a common complication during ostial lesion intervention and may cause ischemia to the myocardium. Using a small and less aggressive guide catheter and avoiding deep guide engagement might prevent pressure dampening. However, this at cost of lack of support from more diffuse disease, CTO or Churcher's vessel, compared to larger and more supportive guide catheter. In case of pressure dampening, we can use a small guide catheter extension to engage and back out with guide wire. And the second point is strong support is crucial in the interventions of CTO. So some techniques to increase guide catheter support include deep guide catheter intubation, large and supportive guide catheters, one or more body wires using microcatheters and guide catheter extension. Again, in the presence of an ostial lesion, the implementations of deep guide catheter intubations or large guide catheter is limited. Meanwhile, in our case, there was sufficient collaterals from the left to right and that guarantee vascularization to the area fed by the RCA. So we were confident in using an aqueous left guide catheter without too much worry for dampening. Here the take-home message, concurrent CTO or ostial lesion of RCA is challenging due to some significant difficulties. Pressure dampening is a potential complications in ostial lesion that should be put into consideration during PCI. And there are several strategies to optimize support in concurrent CTO and ostial lesions of RCA. Thank you for the time.
Thank you. Sadi, we will have another 2 minutes discussion or question.
Thank you. A very great case. Congratulations first for your case. And I agree with you that sometimes we have to stand the ostial first in osteolation before we can see clearly the distal part. But I have some question about the use of guide extension catheter. In this case, do you directly just advance the guide extension catheter or using the balance assisted tracking technique or balance surfing technique in this case?
Because their stents have been deployed in the lesion area, so the function of the guide catheter extensions is to allow a smooth delivery of balloon and stent. So maybe in some cases we can use a swarming strategy, but in this case we just advance the extension catheter to the place.
Okay, maybe some suggestion because some advancement of gate extension cutter can injury the stand and will disrupt the stand. Maybe the technique, one of the two techniques can be used for co-aligning the gate extension cutter. But it's a very great case. Thank you.
Thank you, Dr. Because there is no more question. Thank you for your presentation, Dr. Isana.
Thank you, Dr.
To the sound of your day on your garden, from the deep to your clouds, to the island of the moon. Carry me on the waves to the land I've never been. Carry me on the waves to the lands I've never seen. We can sail with the Orinoco flow. We can sail